Hello, I'm Mark Thomas, kidney doctor at Royal Perth Hospital, where I've been for the last quarter of a century, and for the last 10 years interested in treating Fabry's disease, where we run the statewide referral service and a multidisciplinary clinic. And today I'd like to tell you a little bit about Fabry's disease and also about a screening study we're going to do in our dialysis patients. In summary about the disease itself, it's a multi-system disease which is challenging, which has a delayed diagnosis, major impact on length and quality of life. The high-dose enzyme replacement therapy has been available for nearly 15 years. The oral therapy is under evaluation, and we're very proud in WA to offer a multidisciplinary clinic, which I think is a major step forward. We're hoping to, speaking of moving forward, start screening the dialysis population in WA. So what we're planning to do in WA is proceed with a screening test in all of our dialysis patients and trying to answer the question how many people on dialysis have undiagnosed Fabry's disease. We would estimate, based on other screening dialysis population, that it may be there are 18 to 25 patients in WA among our 1,000-odd patients on dialysis. Very simple process. Once somebody's provided informed consent, we send off a sample of the dried blood spot coinciding with their routine blood tests, and if that is then confirmed on repeat, we follow that up with a gene test and then see them in the multidisciplinary clinic to do a full evaluation. So we have a standard consent form which the nurses would administer once they've had a talk from me, so they become a designated, delegated authority to take the consent. And once the patient has signed it and they've witnessed it, for those patients who wish further information, then that nurse will then pass the patient details on to me and I'll contact them, therefore I only see the patients who need further clarification rather than every patient in WA. So for our dialysis nurses, it's very simple. Once they've listened to this talk, then they have delegated authority. Once they've taken and witnessed the informed consent from the patient, then just write Fabry test on the routine blood test form, and the blood is aliquoted in the Pathwest laboratory and sent to Adelaide for analysis. Fabry disease is a multi-system disease that affects the lysosomal storage. If you have the genetic defect and then you end up affected in the GLA gene, you'll be deficient in the enzyme alpha-galactosidase, which then allows a build-up of the substrate GL3. Classic cases start early, particularly in men, with pain and a gradually progressive rash, and also, interestingly, the lack of sweating. Later on, you'll start to get maybe some GI symptoms, but it's not until the 20s and 30s that you start to get life-threatening organ involvement affecting your kidneys, brain and heart. It's not common, with only perhaps 1 in 50,000 of the general population having the severe classic form, but if you start looking at the high-risk populations, like patients on dialysis, patients with cryptogenic strokes, or attending a cardiologist for hypertrophic obstructive cardiomyopathy, then you'll find significantly higher incidence. And in my nephrology area, we would expect perhaps an average of 1 to 3% of dialysis patients to have Fabry's disease as their possible cause, even though it may not be their known diagnosis. So the disease course is over a lifespan, as early as age 3 in boys and age 6 in girls, with the onset of pain and a rash. And then with the major organ involvement starting later, it can take up to 10 to 20 years before this obscure diagnosis is finally made. And for those who have life-threatening organ involvement, it can shorten your life by 2 to 3 decades, with deaths in the 50s for men and 70s for women. There's a wide variability in how severe people with the gene defect can be affected. And some people have very minor gene abnormalities and some people have very massive. There's also the secondary effect in women who, although they may have one completely normal X, that X will be randomly inactivated at the embryonic stage, and that's a clonal effect that will last lifelong. And if you happen to be affected so that all your X's are inactivated as the normal one, then you will have a disease as severe as a classic male. There are also some different phenotypes where none of the pain or rash or renal involvement appears to occur at all, and they have the so-called lone cardiac variant, and that's seen more commonly in women and also, interestingly, in Taiwan. So the commonest symptom is pain, and this is a very unpleasant burning pain, which may be background dull ache and then unpredictable severe flares, often precipitated by exercise or fever or hot weather. And this can be, in a child, difficult to describe in words, and therefore, as it may get worse with sport, be socially isolating. The standard therapy will be to use neurolytic analgesics, amitriptyline or pregabalin. But when you use enzyme replacement therapy, you can get a very good response to pain. Interestingly, those people whose pain has burned out may then gradually, the pain recur as the damaged nerves start to recover. And then also, interestingly, you'll get return of sweating. And so this may give somebody body odour for the first time in their life. The skin rash is unusual, and it's affecting the dermal blood vessels, so causing a secondary thickening and hardening of the skin. So it's an angiokeratoma, and this occurs in the bathing suit region, around the umbilicus, on the medial aspect of the hands and palms and over the kneecaps. You can also get a stippling appearance over the lips. The second abnormality affecting the skin can be a lymphedema, so that is a differential for patients who have heavy proteinuria with swelling, but it's a non-pitting swelling. The stippled lips can look almost like a tattooed appearance, as you can see on the slide. And other aspects for people who have had the classic disease for a long time can be the so-called facial dysmorphism, thicker eyelids, more prominent jaw, and more puffy lips. It can start affecting the eyes, and occasionally it's the ophthalmologist who is the first to pick up the abnormality, which is not specific. And this star-like appearance in the cornea is only seen with a slit lamp. You won't see it with a standard ophthalmoscope. And it's the same abnormality you can get in response to certain drugs. When a person turns their eye sideways, you look at their sclera, the so-called bloodshot eye can look much more dramatic. And so some of the blood vessels are clearly dilated pathologically. And it can also affect hearing, so you can get a high-tone hearing loss and deafness. All these will be treated by the standard therapy of hearing aids and don't respond to enzyme replacement therapy. Kidney involvement is interesting. You'll see glomerular deposition, tubular cell deposition, vascular deposition. All the different cells in the kidney can be affected. And because the substrate is white, then when you're doing a kidney biopsy, instead of the normal stippled pink appearance of a glomerulus in the tan kidney, you can actually spot Fabry's macroscopically by having white glomeruli. The deposits can occur well before you can detect proteinuria, so the renal biopsy is the most sensitive point of diagnosis, but it's not necessarily done in somebody who's got a clear family history, a clinical phenotype, and diagnostic enzyme and DNA analysis. The progressive renal failure that occurs is a proteinuric renal failure in general, with an appearance under the light microscope that can look a little like focal sclerosis. But not all patients will have this classic appearance, and there can be those who have more cystic kidneys, which can be a diagnostic dilemma. The renal disease is interesting because the glomeruli, when they have the deposits of the substrate, will appear white on renal biopsy as opposed to the normal pink appearance macroscopically. It initially starts as an albuminuria, proteinuria, and in the severely affected males can progress like untreated diabetic nephropathy at as much as 3 to 5 mils per minute per year, particularly those who have established glomerular sclerosis. Conversely, a female or someone with better preserved GFR or lower degrees of proteinuria can have no progression at all or much slower progression. The treatment is both by ACE inhibitors to reduce proteinuria as well as enzyme replacement therapy. It's sometimes sobering to realise how many smart nephrologists have missed the diagnosis of Fabry's disease by attributing common causes and missing an uncommon disease. So a person whose light microscopy shows FSGS but did not have electron microscopy may have missed Fabry's disease. The person who has smooth kidneys and proteinuria, presumed chronic GN, may have missed Fabry's disease. The person who has diabetes and neuropathy and proteinuria may be attributed to diabetic nephropathy and once again have missed Fabry's disease. And for those people who have a lot of cysts in their kidneys and a family history of renal disease, they may be called polycystic kidney disease and once again have missed Fabry's disease. When it comes to looking at a patient with kidney disease who also has Fabry disease, there's some special issues that need to be considered. The low body weight and muscle mass can mean that the true GFR is less than estimated by the standard formula. The problem of GI involvement and diarrhoea can make someone prone to recurrent episodes of acute on chronic renal failure. Lower blood pressure may make ACE inhibitor use problematic. When it comes to hemodialysis, the hemodynamic stress of removing fluid can be hard to cope with if you have concurrent ischemic heart disease, autonomic neuropathy. And when someone is put forward to transplantation, they may be too physically unwell otherwise. But interestingly, the transplanted kidney, which contains normal alpha-galactosidase levels, will not get recurrent Fabry's disease in the graft. The second major organ, potentially life-threatening, is cardiac disease. And basically any form of cardiac disease can potentially be involved in Fabry's disease. So you'll see conduction abnormalities, you'll see valvular abnormalities, you'll see coronary disease, you'll see, and very characteristically, a hypertrophic cardiomyopathy, which may be obstructive. So the standard management follows all the usual pathways of trying to treat valves, treat coronaries, treat arrhythmias, and heart failure, angina. But on top of that, if you can get access for the enzyme replacement therapy, it can help retard progression of the LVH. The neurological disease can take many forms. Some people look like TIAs or strokes, some people look like migraines, and standard treatment will usually minimise some of those. The migraines may have atypical features, such as more kaleidoscopic scotomas. MRIs may show non-specific features of deep white matter changes, which may be attributed to premature ageing. But if you can see also concurrent dilated arteries, it can be the clue that this is the more systemic problem as it's seen in Fabry's disease. Enzyme replacement therapy is thought to perhaps slow the disease, but once you have neurological involvement, it's a poorer prognosis and can recur frequently. Gut involvement can mimic standard irritable bowel syndrome with pain after meals, bloating or diarrhoea. It may be relatively early onset in 10-year-olds, and the management will follow the usual courses of anti-reflux therapy if they've got reflux, FODMAP diet if they seem to respond, and seems to benefit very much from enzyme replacement therapy. That and pain are the two symptoms that tend to respond quite quickly to the start of enzymes. As you'd expect with any form of lifelong multi-system disease, depression is very common, and nearly 50% of patients will have moderate or severe depression, and you usually need a combination both of medications plus psychological support. Either alone is usually not enough. The quality of life reduction can be comparable to that of haemophilia or HIV in a man, or multiple sclerosis or rheumatoid arthritis in a woman, so it's a major impact in those with classic severe disease. You can get lung involvement mimicking asthma or COAD, thin bones and anemia, and all these make it a challenging multi-system disease. And with a multi-system disease, you need a multidisciplinary clinic. And we've been very lucky in Western Australia to set this up with willing, interested colleagues who will come together. We just have one afternoon every 3 months and concentrate on our most severely affected patients. So instead of inflicting many appointments over and over, they come and see all their specialists in one afternoon. So there's a geneticist, there's a psychologist, a psychiatrist, a pain management specialist, a cardiologist, a neurologist, myself, and a clinical coordinating nurse that tries to make this difficult process run smoothly. We also offer preceptorships for the companies that are supplying the enzyme, so they can help understand the patient's journey and also the benefits of multidisciplinary clinic, once again after signing the standard confidentiality waivers and getting administrative approval. And hopefully we'll have a simple answer to a simple study. Thank you.